But just a quick welcome, first of all, from myself. My name is Jay Sloan. My pronouns are they, them. I'm currently one of the co-chairs of the Proud Science Alliance, and I'm joined today by Stephen Ingham. He's also part of the steering team for the Proud Science Alliance. We'll let him introduce himself in a minute, and also Helen Lake. And Helen, let me just access my notes here. I should know this anyway, but I'll tell a story actually, because when we first had the idea for this session, it came about through chatting with somebody within the PSA network, one of the organizations, and we were both kind of talking about getting older as queer people, and we thought, wouldn't it be amazing to have a session like this? I started to investigate, trying to find an expert in men's health in particular, within the queer community, particularly for gay men, and even those who have male bodies. There's so much information and access to information about sexual health and so many people, that we could have reached out to. But what I was interested in is the holistic experience, and that's what we wanted to bring today. I was lucky enough to be referred to Helen, who is a independent urology and specialist men's health expert, and also most recently appointed as a nurse advisor for the Urology Foundation. And in our initial chat, I just knew that she was the right person to come along, bring her energy, but in particular her knowledge and information about the health of men and those with male bodies. So we're thrilled that you're here, Helen, and just wondered, is there anything that I didn't say that you want to quickly mention about yourself?
No, not at all. You did it beautifully. Thanks, Jay. Just, to say I'm really excited to be here. And I think it is very much a neglect. As you say, there's a lot out
Mm.
there on sexual health and that kind of thing. But sort of, just being aware of all the other changes that occur as you get older, that apply to, to males and males who have male bodies and who identify as males. So I'm very excited to be here.
Amazing. Great. And just before we jump in then to Stephen, do you want to quickly introduce yourself so people know who you are?
Sure. Thanks, Jay. So I'm Stephen Ingham. As Jay mentioned, I'm a coach at the Proud Science Alliance on the finance side. Professionally, within my career, I'm up for 20 years so now. And then personally, I'm married. Me and my husband have been together for 25 years and 15 years of marriage. Time is passing. We have twins that are 13 years old. We were a little bit older parents. I think I was 37 when the children were born. Now just turning 50 this year. So yeah, the body's, years are catching up on the body. Let's put it that way. But I think I haven't been to the doctor in 15 years, but I feel in good health. I'm pretty careful in the way I live, and I want to really maintain the energy levels that I currently have for as long as possible to keep up with the children that are racing around still everywhere. So I'm going to listen with interest today to see what I missed in the 15 years that I didn't go to the doctor and that I should be concerned about or not. And yeah, very, very happy to be here.
Amazing. Yeah, and so like Stephen, I'm a little bit older. I was saying that I actually turned 55 on Friday, this Friday. And wow, it just seems like such a, not really a milestone, but I certainly don't feel it. Hopefully I don't look it. But like Stephen, I like to stay healthy and active. I'm big into the gym, that sort of thing. But as the conversation I was having with that I mentioned before, this colleague and I were both saying that we enjoy our work so much, and I don't have this idea that I ever want to retire or slow down, because part of my work is part of my life, and I work independently now as a coach, consultant, and other things. So I don't ever anticipate not working, and part of that is dependent on health. and that sort of thing. And so we're interested in this idea of like, if we want to maintain our physical body, then what are the things we need to know about? And so that was the background. And I think that's often what I hear people talking about, particularly, yeah, I think that's not uncommon, you know, to hear queer men in particular kind of talk about that concept, I suppose. And I think so that was the background of today and why we wanted to have the session. Hopefully, you'll join in as well. So those around the table, so to speak, please do either raise your hand using the function in the Zoom, or just simply type it in a question. Hopefully we're going to keep this informal, and we really want you to join in by asking questions or sharing reflections, that kind of thing. So why don't we jump in, and as you kind of mentioned, Helen, at the beginning, it's important, obviously, to focus on health, and in particular, we don't often see information or ad campaigns or anything like that around men's health, let's say. It's starting to change, as we've kind of talked about, but maybe to start with that and share a bit about why it's important for men and those with male bodies to focus on their health.
Yeah, I mean, it's a great first question, and I think, you know, traditionally health services have been built around females and the family. That's where the money is. The money follows. Sorry to bring up the money tree argument, but you know, that's where the services are paid for: family planning, child rearing, and a lot of screening for female health. A lot of GPs are interested in female health, and there is an absolute dearth of practitioners who are actually interested and who will take on male health issues, and it's becoming a, you know, a real noticeable gap. And over the last 20 years there has been a lobby on the, you know, to actually say, look, we need inclusion and diversity, we need to be able to cover in all bases, and it just hasn't been happening. So number one, males are less, you know, I am going to generalize here, I apologize, but sorry, not sorry, just to give you the sort of flavor, is that men are less likely to engage with GPs. We know this is particularly problematic during the working years. So when you're, you know, when you're little, your parents will take you and you'll go as much as anybody. And then when you retire, it kind of evens out a bit. I think females still go more, but it's all during the working age that, you know, those are the years where there's like literally nothing. And Steve, I was gave a little smile when Stephen said he hasn't been at the GP for 15 years. It's so common because you feel well, you don't need to go. What's in it? You know, what is there for me? What should I, you know, what do I know that I don't know? You know, so I think that's really important. I think it's borne out in the statistics that males do present later. So I am going to come on to some shocking statistics, so that, you know, they literally don't present till the wheels are coming off the bus, as I like to say. So there's some kind of crisis where they can't ignore it any longer, and so they'll go. So there's like a lack of proactive, you know, flagging of problems. Yeah, and I think you know, I think that's very fundamental, and I think it goes across, you know, all demographics.
Yeah. Amazing. So I was like, I was thinking back on my experience because I was born in the United States. I moved to the UK when I was 35, and I was wondering, just a quick follow-up before I come to Stephen, is to ask a question, maybe, is to ask, because there's almost like this culture in the US that you go every year at least, and it's more preventative and that sort of thing. And I noticed when I moved here, that's not the case. I wonder if that's changing at all.
Not yet. I think it's because, as you rightly said, you know, the campaigns aren't, I think males don't tap it. If there are campaigns, it doesn't speak to them.
Mm-hmm.
You know, it can be sort of you know, get your blood pressure checked, and you think, well, there's nothing wrong with my blood pressure, even though there's like no evidence, probably not had it checked for 25 years or whatever. weight loss tends to be coached in a very feminine kind of idea. I don't think any of the campaigns, I think the ones that do work, one that really has been very good over the years is Blood and Pee campaign, because that really speaks, let's just be direct and let's say, look, if you've got blood in your pee, go to the doctors. But I agree, it's the proactive, I don't think that's filtered down. I think it's not in our culture and it hasn't changed yet.
Amazing. Good. Stephen, do you want to ask a question?
Yeah, so maybe just to start with, as I said, having not been to the doctor in so long, what should I be thinking about in terms of just checking? Should I be waiting to be prompted by my GP surgery, or are there things that I should be going out and requesting? Or
no, it won't happen. It won't happen. Unfortunately, I made a little note about, we all get the bowel. I will be talking about bowel screening because that's generic across everybody. It used to be 50, and now they're trying to roll it out, from 40 plus. To just, you get your little kit and you put your sample in and they proactively check for any changes. But males have to actually officially wait to be called to this for themselves as a gender. You've got to be 65 before your doctor will say, come and see us, Stephen, and the reason for that is there is aortic aneurysm screening from 65. And that is because aortic aneurysm is a weakness in the major blood vessels of the body, and men are much more likely to have that weakness. So therefore they are screened, they have an ultrasound scan, but you have to be 65 before you will get called. So everything else really is down to you as a male, whereby there is no currently no prostate cancer screening. I am going to come on to that because that's a very important area. They won't screen you for testicular cancer, that's on you. Anything that's specifically for male health will, basically you are on your own. However, I will say that some GPs, and actually it is more local councils, arrange this MOT, this health check over 50s. Now, not many people know about this, and it was paused during COVID, as many things were. But age 50 plus, you may get an invite to your GP, or you may need to ask. But essentially, you can go to your GP and they will do things like blood pressure. Remember, I said there are no symptoms to high blood pressure. We could all be walking around with, cardiovascular disease and high blood pressure. We wouldn't know, because unless it's massively high, you maybe get a headache. Many people don't know. The good thing now is you can walk into your local pharmacy and get a check, and they can keep you right. So if it's shown raised, they can give you advice. So that's a good little tip. You don't have to go to the doctors for that. But so what they will do at this MOT check is they will check your cholesterol. They will check your pulse. Is it irregular? They might do a blood test. They'll check you for diabetes. And it is very effective at picking that up. And probably will come on to type 2 diabetes later, because it's very, very interesting in terms of male health. But I don't think people know about that. So at the very least, if you come away from today and think, well, I'm just going to ring the surgeon and say, listen, can I come and get an over 50s health check? They won't necessarily do specific checks like prostate cancer and things like that, but they will give you your baseline and look at things like your individual risk factors. So, are you a smoker? What's your alcohol intake? What's your diet like? But also looking at your family history. Did your father have, if high cholesterol? Is there heart disease in the family? What kind of cancers are in the family? So it gives you this sort of idea, and almost like a map of where you are and where you need to be.
Yeah, you actually helped me remember. It was, I think, just as we were coming out of COVID, the GP, because I was living in London at the time, and I did get called in for that. And that's
Yeah,
exactly what they
good.
did. Yeah, they did the
Perfect.
blood pressure, asked me all the questions. I think yeah, actually had to do blood work as well, just to collect, bl-
Brilliant.
yeah, for
Absolutely.
cholesterol and things like that. So yeah, I recommend
Cholesterol.
it.
Yeah, definitely. And kidney function.
Mm.
Some will check
Mm.
liver function.
Yeah.
Uh, but when I think reflect on November, the big
Mm.
event in November, growing your tash and all the rest of it,
Mhm.
they one of their strap lines is know your numbers.
Mm.
And I think that's a good way of thinking about it, is to actually know where you sit
Yeah.
on those crucial figures.
Yeah, and I'm going to come back to a specific question about that. I just wanted to acknowledge, I think it's John. He made a comment that in the U.S., many exec employee packages include annual health screens, which is
Yeah,
true. And what's interesting, I was just saying before we started that that was available when I used to work at GSK, and it was like a tax-free thing, so you paid a certain amount of money. It wasn't cheap, but but I had the sense like there's something wrong with me, probably because as I was saying to Stephen, I was suffering from the symptoms of stress, from work-related stress and stuff. So I thought there's something not right. But it put my mind to ease, and it was very thorough. It's like everything that you can imagine, and everything came back normal, and I just put my mind at ease a little bit.
yeah.
But
Absolutely, it is good. That's a great point raised, because I
mm,
think if you do have these benefits, often
mm,
people don't know what their benefits are. This
yeah,
is what it drives me mad a little bit, that often we have all these fantastic things, and you think, oh, I didn't know
yeah,
we had it. So it's be a good way of sort of, really finding out what are your benefits, and you will get enhanced checks.
mm,
The NHS can only do what it can do, a little bit of firefighting. They would like to be more proactive, active, but obviously at the minute it's really very difficult. So if you can access this fantastic
yeah.
opportunity, I would definitely encourage it.
Yeah. And what would your recommendation? Like, how often would you do something like that? I mean, like I said, in the US, the culture was at least once a year, but like
Yeah,
how,
probably biannually. Yeah. Or, any major, if unless there's a shift and you feel like there's been something, kind of changed in what's normal for you. Is it normal? Is it normal for
yeah,
me?
yeah,
To actually flag it, and, not to wait for that said, you know, MOT, but to actually go in the meantime.
yeah. Okay, good. And so why don't we start to go a bit deeper and we talked generally speaking what we need to pay attention to, and even, how often and that sort of thing, just to get things checked. But what would you describe as like the major red flags, things that we need to know about, or pay attention to as we start to age?
Yeah, and I think again, it's very difficult, because allied to what I was saying before about, females and children going to the GP a lot, we pick up a lot of messaging.
Mm,
So, we might get on the scales, we might, we'll know about current innovations, and we'll know about things like red flags. Whereas I think, because males aren't maybe accessing that sort of little hub, they're not going to pick that up particularly. So the main ones, I mean, just to sort of give you a little bit of a statistic, I did promise I would give you a statistic, and so, gird your
we love
loins and all
those.
that. You like a statistic.
Yeah.
So first of all, the Office of National Statistics, did announce the first significant decline in male mortality since the 1980s, for the first time. So one in five males will die before they're 65. Okay, before the pension is claimed. All right. And that actually will escalate to 2 in 5 before the age of 75. And it's about 1 in 9 in females. So we're nearly at double.
Hmm.
So And again, in the sort of spirit of inclusion and diversity, is we must mention demographic in terms of deprivation. So if you live in Chelsea, you are likely to live at least 22 years more than if you live in certain wards in Blackpool. Okay, so that's
Wow.
you know, that's going down another route, but you know what I'm saying here. So there's a few horrible statistics, but the red flags are any bowel changes. Now, considering, this isn't a male-specific cancer, but it is a cancer that kills men. So whether it's embarrassment, whether they think, oh, it's a one-off, I don't know, so they present late. So it could be wind, blood in the stool, never ignore blood anywhere where it shouldn't be. Number one. So, flatulence. I know it might, you could just say, well, I've just had a curry, but if it goes on, and you're windy, or you suddenly go from going every day to every 3 days, or then you have sort of the runs, then that is a red flag, and you must go. Blood and urine, even if it's once, it's and especially if it's painless, because I suppose in females, a lot of the time, you would expect to get a urine infection just because of the anatomy. The urethra is very short. In males, the urethra is obviously a lot longer, so there's less likelihood of infection, but it can happen. So if you are a male and you are passing blood, that needs to be investigated. So definitely that's a red flag. Also, any alteration in urination. Now then, you imagine the scene of your sort of, your archetypal blokes in the pub, if I have this pint, I'm going to be up all night. Oh, I know I'm up all night, and it almost makes it acceptable that as you get older, you're just going to go backwards and forwards to the toilet, and you're not going to do anything about it. But actually, if this persists and you're constantly the loo, you've got poor flow, you feel like you haven't emptied your bladder, you are up at night all of a sudden, you can't get going, all of these things are possibly, it could be just an indication of a benign enlargement of your prostate, okay? Because unfortunately, cancer in the prostate and benign enlargement will give you similar symptoms, but there again, flag it. Definitely persistent coughs, lung cancer, massive in males. Again, males will die more often of the cancers that affect both male and female. I think they're 45% more likely to die of a cancer that is common across genders. Skin lesions, oh my God, melanoma, and more women, I think more women get it, but more males die of it. And again, they go late. I mean, there's been some fantastic strides in sort of curing melanoma now, but less likely to use SPF, depending, I am general.
Sure.
But lumps in testicles, and actually a big one I'm going to mention is erectile dysfunction. That is a red flag. It's a red flag. It can be a canary in a coal mine for cardiovascular problems. And you will get it from time to time, stresses of life, you've had a few beers, it's been, you're exhausted. But if it goes on and the spontaneity's gone, or the lack of morning erections, or loss of libido and all of that, red flag.
Yeah. All really helpful, I think. And I think what it makes me think about is like there's something externally that we notice that is an indication of a potential problem internally. And as you said, the tendency is to be like, it's fine, it's fine, it's fine, it's fine, it's fine. It's just, it's not really a big deal, or it's just happened this one time, or that sort of thing. But I think you're really clear of what to pay attention to. and then what to do about it. But yeah, super helpful. Did you have
I think
another
as well,
question?
what's fascinating to me just there with the erectile dysfunction and canary in the coal mine comment, which I think is wonderful. I think that there may be a tendency, if I work for a company that have done a lot of had a lot of success with Cialis and
Oh yeah.
erectile dysfunction, and I think there would be a tendency for many just to reach for the medication.
Oh, that's
It's a very common condition. Medications are easily available for it now, but I'm interested that you call it the canary in the coal mine. You really shouldn't be doing that if
yes, I made a note of that. That's such a good point. It's such a good point. I did make a note of that because I think that there's a few things going on here. Embarrassment, you don't really want to go to the GP because you think, well, there's so many adverts at the moment targeting, the ED medication, which I think is, on the one hand, it's great that it's opened the conversation and reduced the stigma. I think I just absolutely love that. What I do absolutely hate is the fact that you can't access many of these medications on the National Health Service. So, if you can pay for them, then that's all right. And and you might have to sort of fill out a little questionnaire. Doesn't place going to your GP and saying, look, because remember the arteries that supply the penis are smaller and they're going to block quicker before the arteries that supply your heart. And I've heard it said, and the research does tell us that it's about 3 years before there might be a cardiac event. So yeah, I think that if it's, if if you're sort of thinking, well, I need a bit of a hand, and that's absolutely fine. But I think that if you are persistently having this problem, you really need to get checked out from the cardiovascular point of view, especially if you're sort of 45 plus, I would say.
Yeah. Yeah, and another really good comment to go along with that, again, from I think it's Jay. I'm pretty sure I remember John. I'll just say Mr. Newton, Mr. Newton, says that meds like Viagra, OTC, are often cheaper than addressing the bigger underlying issues.
I agree. I agree. And a lot of, there are, there's lots of different medications, and there's, I think if you've got certain, if you're, for example, if you are diabetic, if you're type 2 diabetic, you can access medications on the NHS, but it's just, as they say, having that conversation with your GP. I mean, there's been loads of research done. I'd rather, I'd rather run down the street naked than go to my GP and tell them about my ED. It's really, it's hopefully one good thing about the adverts is that, we had Pele, didn't we? 10 years ago, that was like, oh my God, Pele is talking about ED. For those of you who don't know Pele, you might be under 40, but one of the best footballers that ever lived. I think the conversations are brilliant, but the access to treatment and the safety element needs to be much more acknowledged.
Did you have another follow-up, Stephen?
Yeah, picking up on the melanoma comments that you were making, and I think one of the challenges that my father had when he was diagnosed with melanoma on his head was the speed at which the NHS works, and the appointment scheduling for going by the NHS was terrible, really terrible, and this thing was growing on his head really quite rapidly. And so he went privately to get the diagnosis, and the consultant put various buzzwords in the letter that meant he was then into an NHS appointment 2 weeks later, and he had it removed the week after.
2 week wait.
And alternatively, he would have been waiting months to actually get the diagnosis and engage in that treatment that he needed. And it was a malignant tumor in the end. And you just think, oh, goodness me, if he hadn't been able to afford the the private diagnosis, where would we be now?
Absolutely, it's very patchy. I'm sorry to hear that, and you know we've had a lot of family experience with melanoma, and it should be a 2-week wait. It should be a 2-week referral. I think it really is patchy. It depends what your local services are like, but all I would do is, you know, you've just got to be your own best advocate, or have somebody to advocate for you and say, look, you know, this is a big change and we want this looked at. And I know that's really hard. So people are not of that nature. But once you get past the receptionist, so apologies to any receptionists here, they do a great job. But you know, you need to, you know, you almost need to really overemphasize, and I know that's sad, but yeah, really you should be, because you can't tell by looking at something. It doesn't matter who you are. You know, it's easy to say, oh, that looks all right, I think that's fine, but you don't know, do you? So let's get it checked out, and let's insist on getting it checked out. Yeah,
I think
it's
that's
good.
definitely one of the things I'm taking away, you know, because I don't necessarily fit into the category of like I don't want to see the doctor, but I always feel like I'm healthy, and so like do I really need to prioritize it, you know? And I think having just moved to Wales, I was like I finally registered with our you know the surgery here, but also I'm thinking about right, I need to be much more proactive and kind of in having that sort of attitude, and I think it's much more prevalent. I was just thinking back to the situation where my nephew was in the hospital and my dad was there with my stepmom kind of looking after him and that sort of thing. And I said, "What's going on?" You know, and after a couple of days, and he said, I don't know. The doctor doesn't say anything, or like he says this." I was like, "Well, you know, you can ask him." You know, and it's like it's sort of
Yeah,
a generational thing, and it's something switched in his mind, and the next thing I know, he's having a meeting in the afternoon with all the consultants and everything around the table, and like being a bit more proactive. But I think this is a message to take away, that this is about informing ourselves, but then what are you going to do with that? It's about being proactive ourselves and not necessarily waiting for an invitation or something like that.
yeah. Yeah, absolutely, absolutely. I agree.
Mm,
And I think sadly, but that
mm,
has to be the case. It's just we have to be our best advocates.
yeah.
Uh, and you know, write things down. You know, a lot of
Mm,
my patients will say, yeah, but I can't get an appointment. You know, can't get an appointment. What? So, you know, don't wait till you want one tomorrow. That's never going to happen unless you're bleeding out. Honestly.
yes.
No, so you know, kind of decide, look at you, you know, just say, right, I'm gonna make an appointment in July the 7th or
Yeah.
something, and then make yourself little notes. When were the changes? What were the
Yeah.
symptoms? And go armed and say, right, these are the changes. This is not me, and I want something done about it. And they'll be good. It
Yeah.
should follow.
Yeah, really, really good advice, in particular around the details, because as you mentioned, things aren't always easy to talk about, you know, but I think you just have to go in with the attitude is like, I'm gonna check my check my attitude or shyness or whatever at the door and just be really open. I think too, if we think about it, we show up to the doctor, they are the experts, they've heard everything, probably seen everything. So it's not like we're gonna shock them.
No, they've
Yeah.
heard it all. Absolutely.
But thinking about that too, I mean, we talked about a little bit about generally what to pay attention to, some of the red flags. I wonder if you can talk more generally about, because I think sometimes we don't have the information about what actually happens to the body as it ages. And then we're talking about the male body here. So what are the things we need to, you know, be aware of? As I mentioned, I turned 55 on Friday. I've noticed, you know, in the gym, I can't do what I used to do,
Yeah.
even walking around and things like that. So I noticed certain things, but what are the other things that we need to just be aware of that are
Yeah.
going to change?
Yeah, so I think fundamentally we need to be aware. I mean, hormones, but we're going to come on to that, I believe. I'm going to leave
Mhm.
hormones for the end.
Okay.
So muscle mass and strength,
Mm,
definitely, you know, as part of the aging process, it's associated with gradual muscle loss and um, you know, sort of certainly regular exercise, particularly as you
Mm.
say, resistance strength exercise can really mitigate that.
Yeah.
Because, you know, you can imagine, can't you, when you see sort of images of the, you know, elders who are, you know, well into the 70s and 80s, they've got an upright carriage, they've obviously got core strength, you can see that they've been fit in their time.
Mhm.
If you can do that in these years now, then you are going to set yourself up for such a you know, a really sort of in elder years with vitality, with energy, and with less ill health and less ill chronic ill health. You know, it can preserve strength, which I think, you know, because then the opposite of that is, you know, you're sort of, you know, bent and, you know, lack of strength. So it does work, and these are the crucial years. So I think the middle years are really, really important. I think bone density, I think you hear a lot of sort of, you know, obviously with the menopause,
Mm.
you know, females are at risk of osteoporosis. But, you know, men are also at risk from osteoporosis, you know, decreased density if they're not exercising, because
Mm.
obviously the more you exercise, your bones get stronger.
Mm.
And then, of course, calcium intake, vitamin D, all of these things, and weight bearing exercise are really important. So I think, you know, definitely muscle mass and strength and bone density are your number one. Then, of course, cardiovascular. In males, definitely increased risk of hypertension, of atherosclerosis, that's the laying down of the all the gunk in the vessels. And in actual fact, even, you know, over a lifetime, and there's evidence that you build this up from your teens.
Mm.
You know, actually some really good evidence to suggest that even if you've got these deposits, if you continue your exercise, then the vessels get a little bit larger around these deposits, so they're
Mm.
not going to block. So it's never too, what I'm trying to say is it's never too late to
Mm.
start.
Mm.
Even if you've already got that sort of build of plaques of atherosclerosis, you can sort of widen and get the blood flow and all the rest of it. It's never too late for that. And obviously lifestyle factors like smoking and nutrition. It's what I always say, it's the usual suspects. No smoking, reduce your alcohol, exercise, eat a rainbow, cut out the processed food.
Mm.
You know, I almost want to put a little insert of that film, The Usual Suspects, because we all know what they are, and
Yeah.
it's kind of trying to get that. Um, Prostate. We're coming on to the anatomical prostate, which it's a mighty little gland which can cause a lot of problems.
Mm.
Okay, so it starts to grow from about 40. And it's age related. Nobody knows really why particularly, but it's to do with your fallen testosterone, makes your estrogen levels a little bit more robust, and it starts to proliferate the cells, and it can cause obstruction to your urinary flow, and it can give you things like wanting to go a lot, wanting to go just after you've been, and up at night, and it can be, you know, you can have very large prostates where people don't have the symptoms, and
Mm.
it's very individual.
Mm.
Tends to be dad had it, you have it. Tends to
Mm.
be that way. Um, so definitely look out for that one. And again, this is separate to prostate cancer,
Mm.
because prostate cancer may be picked up during that. Because I think what we may need to really briefly talk about is if prostate cancer checks when you don't have any symptoms. That's kind of different. So you've got your symptomatic men
Mm.
who have problems with you know, their urinary flow, and males who are absolutely fine but could have prostate cancer because it hasn't manifested yet. So can come on to that. I suppose sexual health, ED, we've talked about
Mhm.
ED. Again, the connection with cardiovascular and metabolic.
Mm.
Um, males experience changes in metabolic health, and again, it's to do with you know, there's more obesity now, particularly in men, unfortunately. And what happens is estrogen can be released from the abdominal fat, which can then affect how your body metabolizes its glucose, and you become insulin resistant. I don't know if many of you have heard of that. So abdominal obesity combined with decreased muscle mass can actually lead to things like type 2 diabetes, and it's more prevalent in men. I think they're not, it's about 28% more likely to get type 2 diabetes. And then you're looking at a chronic metabolic disorder, high blood sugars and things like that. So they are the main things: cardiovascular, prostate, muscle, bones, and energy levels.
That was super helpful because I got this picture almost of like, make sure everything's flowing, your blood, urine, stool, everything. You know, this flow is one thing, and then also about kind of bones and muscle, and kind of look after them both. With that all has impact on metabolism, that sort of thing. But Stephen, it looked like you wanted to come in.
Yeah, I had a sort of follow-up question on the prostate component there, and I'm thinking that, you know, we must be like 2 decades plus into the hair loss treatments, the finasterides, and I remember reading something about the masking of symptoms for issues with the prostate as a consequence of those hair loss treatments. Is there any developing evidence on this, you know, two plus decades in, that this is actually an issue? Or
Yeah, I mean, that's quite an interesting question, actually. So yeah, you're right, finasteride is used for hair loss, but it's also a medication that men are put on for symptoms of outflow obstruction. So I'm guessing that if you're on that for a different reason, then you may not get you're absolutely right, you may not get those telltale symptoms of the outflow obstruction. So yeah, it's I don't think it's been particularly looked at, because I think there is still a demand for that treatment for hair loss, whether or not they'll ever develop anything else that's a little bit you know, less impactful, because really it is quite a serious drug, actually. You know, it can cause lots and lots of different problems. It can actually, I'm not sure if you're aware, but it can actually cause what's called retrograde ejaculation, where the ejaculate falls back into the bladder. So you actually end up having like a dry ejaculate. So it can cause lots of different problems like that. It can affect your fertility if you're younger. So it's not without its problems. I think in that case, if you are taking it and you're fine, you know, and it's working for you, then to be aware of, you know, maybe just having a prostate, you know, check, a blood test, certainly from 50 plus, just to make sure everything's all right in terms of cancer. And actually that leads me into the screening for prostate cancer, because it's a massive debate at the moment. Prostate cancer research, and the government have just announced a massive screening study called Transform, because up until now, as we've already said, you won't get called for a prostate cancer check, so men are often picked up because they have symptoms. But if you're talking about asymptomatic men who are just thinking, I wonder if I, you know, I wonder what my PSA is. So a PSA is your prostate specific antigen, some of which will leach into the blood naturally, but in prostate cancer, it will be raised in your blood level, but it's also raised for other reasons. And that's the problem. It can be raised if you've had an infection, if you just had sex, lots of different reasons, if you've had a, you know, a UTI or prostatitis. But what it does do is it's the best we have just now. It's an indicator of where your levels are. And if they're raised at one time, your GP would do the digital rectal examination, which obviously a lot of people are not keen on for obvious reasons. It takes 10 seconds and it's over. But now if you're raised, they will send you for an MRI. And then if it's raised, if that shows something, you will get a prostate biopsy, and that's how you would get a diagnosis. But there's a big debate over who should get the PSA test. And my advice would be, if you're over 50, ask for one. You're entitled to it.
Mm.
If you're 45 and you are, if you're Black, or your brother or your father have prostate cancer, 45, you're entitled to get a PSA check. And if your mother or sister has the BRCA gene of breast cancer, and that is not known about widely.
I did not know that. So that's really helpful. It gives me kind of this beginning of a list of things I'm going to take with me when I go.
I know.
Yeah. And you mentioned, yeah, hormone level changes that we can talk about really quickly. I think because my initial foray into science was through exercise physiology, and I learned a lot about the physiological changes of the body as you age. And in particular, because I was interested in the gym and building muscle and that sort of thing, and I was like, my breath left my body when they said, yeah, your testosterone levels start to decrease by the like from 30 on. I was like, oh my God, you know, and I was like, that's about the age I was when I finished grad school. But I can definitely feel it now because I feel like I'm running just to stand still, and probably I feel like I'm losing the race, even though I'm quite in the gym quite a bit and that sort of thing. But what's interesting is that I've been noticing a lot of information lately that's been being shared about hormone replacement therapy, and this is something I'm quite familiar with through talking with my mom initially, but then my sister, and kind of seeing it more prevalent, I would say, in the mindset and the consciousness for women in those with women's bodies. But I'm just interested in your take on this. You know, the kind of rise of potential hormone replacement therapy for men, and what you know about it and what you think about it.
Yeah, it's a great question, and I've deliberately sort of left it out of the sort of unique physiology of their bodies because I think I kind of knew we would make concentrating on this a little bit. So yes, you'll lose it from 30, 1 to 2% a year. It will affect some men, it won't affect others, and we don't know why that is. One theory is that if every male did their testosterone at 17, you would have a baseline, but we don't have that. So one theory is if you are a young male and your testosterone always runs at sort of average, then any sort of fluctuations aren't going to bother you very much. If you're a male who has always had a very high testosterone and suddenly you suddenly plummet, then maybe that's when they are symptomatic guys. Okay, so that's the first thing to say. They and it's very individual. So some of the signs and symptoms would be, now there is something I prepared earlier. It's called the Adams scale. It's called the aging androgen deficiency in the aging male. Okay. And it's a list of questions that are really quite interesting. They essentially your symptoms are diminished energy, low libido, erection changes, reduced vitality, prolonged fatigue, low mood, brain fog, and diminished muscle and bone density. So we have the classic story, which was told by one of my fellow professionals, who the guy was in the kitchen, heard his wife and her friends talk about brain fog, and he thought, that's me. Okay, so it can happen, and it's one of those. I think we're probably about 20 years behind hormone replacement therapy in women. I think it's had a bad press because of, taking like steroids, so it's sort of not given the seriousness in which it should be, and it's certainly not. It always makes me mad when I hear about grumpy old men and pictures of tortoises and things like that. It's actually not funny, and so I get a bit cross about that. So in terms of hormone replacement in males, Sometimes a drop in testosterone may be temporary. It can be affected by aging, but it can also be affected by stress. We've had young guys in our clinic with it in his boots because he was stressed financially. It then resurrected itself. Sleep, we know for a fact that, let's all hope we could get 8 hours a night, but if you have less than 8 hours a night, say 5 nights on the trot, your testosterone will dip. Lack of exercise, but also over exercise. So if you're doing a lot of exercise, that'll drop you'll do the opposite of what you're thinking you're doing. So all of these things. So if you've got age-related symptoms and you've got ill health, so say you're a diabetic or you've got a chronic illness or you've had COVID. We didn't even mention COVID, but COVID was rife and it was to do with testosterone. That's why many men died. That's a different podcast. Definitely.
Yeah.
So you've got the double whammy, haven't you? You've got these health conditions. Maybe you put a bit of weight on, and you've got age-related. So you try all the usual suspects. If that doesn't work and your levels are low, then TRT, testosterone replacement therapy, is a valid treatment for males who are going through this. Now, what you need is to go to your GP and say, I am having persistent difficulties, and insist on a testosterone test. Having them by all the private means, it doesn't necessarily give you the treatment you need. So you might get referred to endocrinology or urology, a urologist, where if it's certainly in that low parameter, there are gels, there are injections. Once you make the decision to go on it, it is more or less lifelong. So it's a commitment. But unfortunately, the NHS doesn't do this very well, and it essentially means a private clinic.
Well, thanks for sharing that. I think in particular the statement that you made, this is a valid treatment. I agree with that based on the research I was reading as well, because the thing that stood out for me is is the impact to mental health in particular. I mean, we all know. I mean, no one wants to get old and hunched and that sort of thing. You want to stay, have a certain amount of vitality, I suppose. And of course, you can exercise and things like that. But then also, that's what I started to pay attention to more. I let go of the other aspects of it because I guess things that I can do. But I think it's more about, I was like, what if I experience that? Because I've had mental health issues in the past relative to depression, that sort of thing. And I noticed as you get a bit older as well, like you said, I didn't make the connection, but that's the idea of grumpy old men. It's because potentially,
Yeah, drives me mad.
Yeah.
I mean, you wouldn't be able to say it to a female now, would you? Look at her with a hot sweat. It's, let's be honest. It really needs to be a conversation.
Yeah, I agree. And so, and I think, as you say, it's making it not a joke or something to be dismissed, but rather this is a real health situation, just like we talk about cardiovascular health or anything like that. So amazing. I'm just conscious we have just a couple minutes left. I put a note in the chat to ask if there's any questions, but I'll just check in. Anyone around the table have any questions, including you, Stephen? Any last things?
No further questions from me. I'm just very grateful. I have a list of things that I can go to my GP surgery with now and legitimately request, even though I'm feeling fine. So that's very empowering.
Proactive. Yeah.
Thank you very much.
No problem.
Good. And likewise, I mean, I feel like as somebody who's from a scientific background and had a lot of friends who were physicians and nurses, that sort of thing, by proximity, you get a bit of information, but I still felt like there was a bit of a black box, but it feels like the light has been turned on thanks to our guest, Helen Lake.
I hope so. I hope so. That's good because it's empowerment is everything. Absolutely.
Yeah, and just a quick note from Jennifer. Yes, I have to run. This is amazing. Thank you, especially for highlighting all of the connections between body sicknesses and speaking specifically to conditions and screening where messaging is targeting more towards women, but are not specific to women. So it's really important. But agree with that. Thank you for that. Well, good. So I think we'll end there. But just another huge thank you for being with us today, for the open and honest conversation, and hopefully everyone that joined today and even listening to this after the fact is able to benefit like we did. Thank you so much.
Thank you. My pleasure.
Thank you.
Bye bye, everybody. Bye bye.
Bye, everyone.
Thank you. Thank you so much.